Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's award-winning online leadership course, Fundamental Skills for Nurse Managers, with information available at www.aacn.org/manager skills. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. I am Andrea Schmidt, one of AACN's Clinical Practice Specialists, and I am joined by Dr. Vicki Good, our Chief Clinical Officer.
Welcome, everyone.
Today's content is something that acute and critical care nurses often don't think about, but it's such a critical issue that we all need to understand and be able to recognize. According to the U.S. Department of State, more than 200,000 victims of human trafficking were identified in the U.S., and an estimated 27 million people are exploited globally.
Andrea, those statistics are just overwhelming and very scary. And victims often come from some of our most vulnerable people in society, such as runaway youth, immigrants, and those facing economic hardships. Some of the statistics that we've become aware of as we prepared for this is that 75% of victims are females and 40% are children. It is believed that as many as 88% of victims access healthcare during their trafficking situation. But unfortunately, many healthcare clinicians may not be aware of the symptoms or how to even respond if they think their patient may be a victim of human trafficking.
Yes, and our guest today saw that gap in healthcare clinicians' knowledge, and that's what led our guest, Ashley McAree, to educate herself and develop a strategy for her health system and her community on how to respond to the human trafficking crisis. Ashley, would you please tell our listeners a little bit about yourself?
Sure. First, I just wanted to thank you so much for inviting me to your podcast today. I think that, as you just stated, this is such an important topic for all healthcare providers to be aware of. So to have the platform and to be able to spread some information, I just very much appreciate it. So again, my name is Ashley McAree. I am a forensic nurse and the human trafficking liaison with Greater Baltimore Medical Center. And this is a community hospital in Baltimore County, Maryland. And I work for what's called the SAFE program. And for your listeners that are unfamiliar with what a SAFE program is, SAFE stands for Sexual Assault Forensic Examination. And we are coordinated by forensic nurses. We're all specially trained and certified by our Board of Nursing. And we're able to offer services to victims 24/7 and 365 days a year at absolutely no cost to our patients. A little bit about what we do with the SAFE program. We conduct medical forensic exams, where that's a medical exam with also documentation of any injuries, patient reports, and we collect any potential forensic evidence from our patients. We provide prophylactic medications, follow-up care, and also extremely important is the follow-up advocacy services. As a forensic nurse, we also will be called to testify and provide expert testimony if one of our cases does end up in a criminal trial. So I want to talk a little bit about forensic nursing because I went through nursing school. I started my first nursing job and I had never heard that forensic nursing was a specialty. Never heard it before. And a lot of the new nurses that I teach, they had never heard it either. And this is just such a really interesting and very rewarding field of nursing. And the overall across the country, we don't have enough forensic nurses. So any of your listeners that are interested in joining this very cool field, please look into your Board of Nursing and see how you can do that. But with our SAFE program, so when I had started with our SAFE program back in 2014, we only cared for victims of sexual assault that were 13 years of age and above. And when I started with the program, it was right around the time my director, Laura Clary, began managing. And we saw huge gaps in different victims that we were missing. So now we're able to treat sexual assault of all ages, domestic violence, human trafficking, and child sexual abuse. So we're able to offer services across the lifespan, which is just very much needed in our community and across the country. These services are needed. Another gap that we saw was human trafficking. So when I started with my forensic nursing training, we didn't discuss human trafficking at all. It wasn't a topic. It wasn't mandated by the Board of Nursing for our education. And we began seeing patients, but really had no idea what to do with these patients. We didn't know the correct response. We didn't know what services were available. So that's at that point, around 2016, we created the Anti-Trafficking Initiative to meet the needs of these victims. And that mainly consists of policy development, staff training, and different services for victims. So within the SAFE program at GBMC, we're able to do human trafficking specific medical forensic assessments. We added a screening tool to our EMR to help better identify on the front lines. We offer emergency shelter for our patients, getaway bags that are filled with clothing, toiletries, items of necessity, gift cards, track phones, and we can connect them to specific resources in our communities related to human trafficking. So that's kind of just in general my background and what we do with the SAFE program there.
Thanks for that great overview. And it's amazing how you've been able to increase your services, because I know some programs are very small, very focused, and a lot of it also has to do with what your Board of Nursing will allow you to do as well. So I do, want to encourage our listeners to understand that aspect of this as well, because you've got to understand that aspect. But help us understand, because human trafficking has been going on for quite a long time. People are just now becoming aware of what human trafficking is, but I think there's still a lot of people that don't understand it. So help us understand, what exactly, when you say human trafficking, what does that mean? What does it look like? And what are some of the common myths out there surrounding human trafficking?
Absolutely. So I like to always, when I'm doing any type of training on human trafficking, I like to start with the myths and the reason why there's so many misconceptions out there about human trafficking. And I was one of those clinicians that before I started in this role and really started to dive into, what exactly is this and why is it important to me? I had no idea. I believed all the myths. I thought it only occurred overseas. There was never going to be a human trafficking victim at my small community hospital. And I was very, very wrong. So first, I want to encourage all of your listeners to Google human trafficking victim just to see what kind of images pop up. This has certainly gotten better since I started the work around 2016. In the past, when I would Google it, it would be mainly white women that are chained up, tied up, hands over their mouth, beaten pretty severely. And this is the general view of what trafficking looks like in our country. And this is incorrect. It's important to talk about the myths because they're harmful to victims, especially from the healthcare side. If we believe that victims are tied up and beaten and they are supposed to look a certain way, we're going to miss them. We're not going to identify them properly, and we're not going to be able to get them what they need and services that they need. So some of the common myths, it's only female. And we do know that the majority of sex trafficking victims are female, but there's many men and boys that are also victimized by this. Another big myth is that traffickers are strangers to their victims. These are just strangers that are kidnapping people off the street. And I'm not saying that never happens, because it does, but it's so rare. There's a system to trafficking. There's a recruitment phase. There's a grooming phase. There's lots of different things that happen in these situations. And it's with the grooming process, it's a long process at times. It's not just kidnapping. The majority of victims know who their traffickers are, whether that be a friend, a family member, a romantic partner, someone they trust. Another big myth is, again, that victims are tied up, they're confined, they're kept in dark basements. Again, this could happen. This does happen, but it's not as common as one would think. The majority of victims are more controlled by a psychological type of manipulation. And another big myth that is really hard for us, especially as healthcare providers, to get past is that if a victim is offered help, they're going to take it. Or if you ask a victim, do you need help? They're going to say yes. We expect victims to disclose, and a lot of times they don't disclose. A lot of times they won't accept our help. There's so many different factors in why that happens. But we have to be aware that if you ask a patient, a series of questions about trafficking, they may say no to all of them, but it doesn't mean that they're not being victimized. So as far as what trafficking is, there's two main types. We have sex trafficking and labor trafficking. I mainly train about sex trafficking because of the field that I work in, but labor trafficking is just as important, and it's just as important to be aware of. But labor trafficking is when a controlling individual, so a trafficker, uses force, fraud, or coercion to exploit someone for their labor. And for sex trafficking, it kind of goes into two sections based on the age of the person. But mainly sex trafficking is a trafficker, controlling individual using force, fraud, or coercion to facilitate a commercial sex act. And that commercial sex act could be any sexual act in exchange for money or anything of value. So it could be money, drugs, it could be a ride, it could be gifts, it could be anything. The difference between adult and minor sex trafficking, so adults, you have to have the force, fraud, or coercion for it to be considered trafficking. For minors, as long as there's involvement in commercial sex, regardless of any other factors, they are a human trafficking victim. So this could be a minor who is self-posting ads online, exchanging sexual acts for money. This could be a minor who is involved in survival sex. This is where we see our homeless youth, the children that are runaways, that are homeless, and they're exchanging sexual acts in order to get some food, get some clothes, like have somewhere safe to stay. So it doesn't, for children, traffickers may be involved, they may not. And they may be force, fraud, or coercion, but there may be not. As long as that child is involved in commercial sex, they are a sex trafficking victim.
So much information, and just really hard to wrap your head around how much it really truly exists in this country. Now, you've described human trafficking as being hidden in plain sight. So I'd like to know what you mean by that, but I also want you to share with our listeners, as nurses, what signs should they be looking for that indicate that their patient is potentially being trafficked?
Sure. So yeah, victims are hidden in plain sight. I mean, sex trafficking, labor trafficking, it can occur anywhere. It could be on the street, it could be in hotels, it could be behind closed doors in a victim's home, or it can be completely online. We have seen sex trafficking victims that are targeted and exploited online without even leaving their bedroom. There are many signs that anyone in the healthcare system can watch out for, and red flags that can be seen in order to identify trafficking. And that's why it's so important to identify all staff members. Nurses are typically on the front lines. They're going to hopefully identify the most, but even training registration staff, food and nutrition, environmental, really anyone can see some of these signs. So I will break it down into behavioral signs and physical signs. So for behavioral, this could be patients who are not in control of their own documentation or identification. So if they come up to the triage desk, they're registering as a new patient, and someone else pulls their ID and their insurance card out, that would be a red flag. If the patient is with someone in the healthcare system who is insistent on speaking on their behalf, or if the patient is speaking for themselves but looking to another person before answering to get that approval, huge red flag. Another one is if the person accompanying the patient is resistant to leaving the room. They don't want that patient alone. That's an issue, and that's something we need to look further into. Any signs that your patient is being submissive, if they're fearful of another person, if they're resistant to professional interpretation services, if they don't speak English, because if we have anyone translate, we really don't know what they're saying. So we always need to use that professional interpretation through our facilities. And then as far as physical signs, so these are the signs that we're going to look out for as we're doing our evaluations and assessments. So any signs of physical or sexual violence or abuse, if our patients have multiple pregnancies, multiple miscarriages, abortions, or they have frequent sexually transmitted infections, any signs of substance abuse. So we have traffickers will either target people with existing substance abuse problems, or they will use it as a method to control their victims. If they're malnourished, if they're exhausted, some other big ones, if there's a delayed presentation for medical care. So if a patient comes in and they have this severe injury, but they waited 2 weeks to get care, why is that? Why is this patient waiting so long to come in for a severe burn or a fracture? You really want to look into those types of things. If your patient has untreated or undiagnosed medical conditions, we want to ask, like, has this patient been denied access to their routine medical care? Why isn't this patient being treated for their diabetes or their high blood pressure? And another one that is one of my favorites is that the injury does not match the history that is given by the patient. So if you, as a professional with your training, look at what the patient is telling you and the injury, and the mechanism of injury that they're explaining and they're describing doesn't make sense and it's not plausible, that is a huge red flag. Because if they're not being truthful about how it occurred, you want to look into that. It doesn't necessarily mean this is absolutely trafficking, but something else is going on that we need to consider. And another big one that can't really be explained, but just our gut feeling. Us as clinicians, we are with patients day in and day out. When we have that gut feeling, you might not know why, but something is wrong and we need to trust that gut.
Yeah, and oftentimes our gut is right before anything else is right. So it's kind of that sixth sense that we have as nurses, right?
Absolutely.
Some of these signs sound so similar to domestic abuse too, though. So it's like it could be really then one or the other is what I'm hearing you say. Just know something's wrong and look into it further.
Absolutely. Yep. So these are just red flags. These aren't going to say this is definitely a trafficking victim, but just some nice red flags for you to be able to help identify that something is going on and try to have a conversation with your patient about what that might be.
So looking at that makes me wonder, because we know how busy nurses are, right? And these victims can be identified in the emergency department, in the operating room, when they get up onto the floor, in the ICU, I mean, anywhere along the pathway of healthcare. So knowing that nurses are trying to prioritize multiple different things, and when you think about all the different things that need to be done for these victims, so mandatory reporting, do they fall into mandatory reporting, such as child and elder abuse? And then if they do, how do you prioritize getting that report done with all the other things? So how would you recommend that a nurse prioritize the care of these patients?
That's a tough one. And it really depends on your state laws and also the facility that you work for. With our nurses at GBMC, we have the forensic nurse program that they call for any type of issue. And then we would kind of take over and assist with that mandated reporting when needed. But as far as mandated reporting, again, it's state by state. So it's important for all nurses to know what their state laws are. The majority of states in the United States does not require mandated reporting for adults of human trafficking, just like domestic violence, unless it's a vulnerable adult. And that's many different reasons. But for children across the board, report immediately. Even if there's a suspicion, you don't need any proof. If you have enough red flags and you can reasonably say that you suspect that this pediatric patient could be a victim of human trafficking, it's important to just report it immediately. And then use your teams. If you work for a facility that has social worker, if you have any forensic nurses, if you have anyone else that can assist you with making those reports, reach out to your team, because I understand that, especially in an emergency room, we're so busy and we're juggling so many patients that it's hard to prioritize things like that. But it's very important as well.
What are some of the differences that a nurse should keep in mind when they're dealing with a suspected human trafficking situation when it's adult versus a child under 18 years of age?
So again, with the mandated reporting, with children, it's an absolute mandated report immediately. With adults, I know I want to talk a little bit more about that later, about the actual response as to, what the recommendation is about what to do. But with adults, it's really just trying to have a face-to-face with that patient and letting them know, I care, I'm here to help. What can I help you with?
So I know that healthcare organizations, and we've got listeners from all sorts and varieties, from critical access hospitals, community hospitals, university centers. We all have different resources available. So some of our listeners may be listening to this and thinking, gosh, I wish I had an Ashley on my team, to help me with this, but they may not have those resources. So if a nurse leader or a team is trying to set up a program, or at least even set up some fundamental resources, where do you recommend they start?
So there's lots of resources out there. And I do agree. I think that every healthcare facility should have some type of policy or some type of support specific to human trafficking. There was a study from either 2019 or 2020 that estimated only 1% of hospitals in the entire country have a policy specific to human trafficking. So pretty much across the board, we need to do better. Unfortunately, some hospitals don't have the support like others do. Like, we are very lucky at our hospital where we have a lot of support from our leadership, but not everyone has that. I had met a nurse recently from another state, and she wanted to start an anti-trafficking initiative, and she has been shot down every step of the way. But for anyone that is interested in starting any type of anti-trafficking initiative, there's so many resources available, and steps to take. First, I would say identify a champion who is going to lead this initiative. You want to identify stakeholders. So who is already in the community doing this work, and how can you all work together? Who are the resources in your area? If you do identify a patient, where are you going to send them? We need to know what kind of services are offered and where we're going to send these patients. And you have to have all of this planned out on the front end. Also, approach the decision makers of your facility, approach the leadership team. We want to discuss the importance of the work, because if they are like many of us, they believe the myths of human trafficking, they're not going to see the importance in trying to combat it. You can use national recommendations from organizations like the Joint Commission or the American Hospital Association. And another thing that I like to recommend is bring up the probable noncompliance that's happening with mandated reporting. Like, hey, we're not fulfilling our obligations, and we need to have some education that could help with making sure that we are fulfilling those obligations and reporting children, or we're going to get in trouble. Another thing would develop the policies and protocols, any procedures that you need. For this, you don't have to reinvent the wheel. There's a lot of state hospital associations that do have recommendations in place for all hospitals throughout your state. There is a great program called SOAR, that's SOAR, and that's through the Office on Trafficking in Persons. And they're with the Department of Health and Human Services. They have a protocol for, or they have a recommendations for protocol development.
And Ashley, just a follow-up to that question. I understand there's a couple of different professional associations out there as well for forensic nurses. Is that the case?
Yes. So we have the International Association of Forensic Nurses and the Academy of Forensic Nursing. And there's also, related to the policy development, there is an organization called HEAL Trafficking. It's HEAL. And they also have availability of a comprehensive protocol toolkit to help with building any kind of protocols in a healthcare facility. And then to add on to the trying to build an anti-trafficking initiative, I think the last piece and one of the most important pieces is staff training. So it's important to create the policies, but they're not going to be followed effectively if the staff don't know they exist and don't know why they exist.
Yeah, and I think it's important for everyone to understand you're not out there alone starting these programs. There's lots of different resources available.
And I think that's a perfect segue into my next question, which is education. So we know that obviously that is a critical element for helping victims. So you developed a training program for all of the hospital staff at your facility. What were some of the sources that you used to set up the training? And is this something that an individual nurse could do if they wanted to just educate themselves if there's not a program in their organization?
Yeah, absolutely. So we have training for all of our nursing staff. They get trained annually on human trafficking. And we also have training for other disciplines as well. So we train law enforcement, first responders, judges. We go to nursing schools, community members, like anyone that will listen to us, we get in there and talk to them. And just like policy development, we don't need to recreate the wheel. There's a lot of resources available. So again, SOAR, the SOAR, they offer free training with continuing education credits that are available, which is great. HEAL Trafficking, HEAL Trafficking, also has some great training programs on their website. And then if you do create your own, like we did, any effective training is going to include different things. So one would be survivor input. We want to have survivor input on everything that we do to make sure that we are remaining victim-centered. And the training should include the definitions of human trafficking, the risk factors, any signs and symptoms of victimization. Safety considerations are very important. The mandated reporting, the recommended responses, and then available resources that are both national and local.
Let's talk about community resources, because sometimes those are critical links in this equation to solving human trafficking, or at least breaking the cycle. So what kind of community resources do you recommend that people reach out to and partner with?
Any type of victim service agency. If you have a victim service agency, a lot of the agencies that work with domestic violence or sexual assault victims also cover human trafficking. So it's important just to reach out to anyone in your area that may be able to provide any type of resources. Sometimes these crimes often overlap as well between domestic violence, sexual assault, and human trafficking. And then another one would be the National Human Trafficking Hotline. So you could either go online or call them, and they will give you a list of resources in your area.
Oftentimes nurses are dealing with multiple competing priorities. So when they do identify a potential victim of human trafficking, what are the recommended steps or actions that they should be taking?
Cases are not black and white with human trafficking. So there's not really a one size fits all approach. But the number one priority should always be safety. For children, if it's a minor, the safety of that child and quickly reporting to law enforcement or the Department of Social Services. In our case, at our hospital, we do both. We call both one after another, even though our mandated reporting laws say call one or the other, and then we would be fulfilling that obligation. We do both, just so everyone can kind of get their boots on the ground at the same time. And for adults, it's case by case of what you need to do. If the adult patient is alone, you can simply express that you have a concern. You can ask them if they need help. You can try to connect them with resources. You can explain what help is available, and doing all of this in a trauma-informed way. If the patient comes in with someone else, regardless of who that is, regardless of whether this looks like a friend or a concerned relative or a mother, don't ever ask any human trafficking related questions with anyone else in the room. So try your best to separate them. Again, one of the behavioral signs for trafficking is resistance to separation. So do your best, be creative, try to separate them without raising suspicion of the trafficker, because we know what's going to happen. The first thing they're going to do is take off and leave AMA if they think they're being suspected. So some things you can do to separate is you can say, this is our policy to only allow the patient back. It's the policy across the board. We're not picking on you. You can take that patient for a urinalysis and say only one person allowed in the bathroom, and at least you'll have a small window to be able to have a conversation with them. You can say that they need an X-ray. Sometimes someone from registration can come grab that accompanying person and say, we need to take you back to the registration desk just to fill out a couple more pieces of paper, like anything that you can do to get them separated. But if there is still resistance, continuously assess for safety. If you feel like safety could be jeopardized, just stop. Just do your best, but we don't want to cause a safety concern for us, for our staff, for other patients, for the patient you're meeting with. So that's a big one, and that's the one that's toughest, I think, for staff, is not having the opportunity to have that conversation. But if you do speak with any suspected victim, just make sure that they're alone. Make sure they don't have a cell phone in the room with them, because sometimes they're monitored through that cell phone. So we want to make sure that they're able to speak freely. And then if you do have a conversation, like, let them take the lead. So all you can do is express concern. You offer resources, offer help. And really, ultimately, it's their decision as to whether or not they're going to take it. So we don't want to force them to answer questions. We don't want to force them to accept help. We really want to respect their decisions. And then again, just utilize our teams, maybe consult with social work, or call that National Human Trafficking Hotline to access resources or access any help. So if you call that hotline and you have a patient in front of you, you're not sure how to proceed, they can help guide you through the best response in that particular situation.
I was going to ask, if you do get the human trafficker separated from the victim, and they agree and they tell you, yes, I'm being trafficked, and or whatever terminology they may use, what do you do then? Do you let the trafficker back in? Do you go on like everything's fine and work in the background? I'm really curious.
So again, this would be very case by case. And sometimes we have to use our best judgment and we have to be creative along the way. If if the patient, say you have the patient in a bathroom and they say, yes, I need help. What kind of help can I do for you right now? Do you want me to call the police and let them make that decision? Do you want me to get you a phone number that you can stick in your shoe and you can call later? Like, what is best for you in that moment? Because just like domestic violence, like, we don't know their situations. They know their situation best, and they'll know the best way to navigate that. It's really just sometimes trial and error, and sometimes just reaching out to your team for assistance. And there's no absolute right way to do it, other than having those direct conversations with the patient and saying, how can I keep you safe? If there is a situation where the patient says, I don't want to be with this person, I want to notify police, take them to a secure area and get them out of the emergency room, alert security, alert police. This is, again, why it's so important to train all staff. If we only train nurses, and nurses know the correct way to do things, but we don't have our security staff trained, they're going to have no idea what to do. So it's important to use your teams, important to include your team members when needed, but also don't include your team members at times, because we don't want to alert everyone in the emergency department that there's a potential trafficker in room 3, because everyone's going to go in and start looking around, and we don't want to raise that suspicion. So it really just depends on what that patient needs in that moment, and what kind of help you can have them accept.
So Ashley, this kind of spurred another thought in my head is, what about the nurse that's concerned about their own personal safety in these situations? What should they do differently?
That is also a great question. These situations can be extremely dangerous. That's why it's important to notify security if you have any type of concerns. Sometimes security can do more frequent rounding. Security can stand by the door. We shouldn't be putting ourselves in danger to take care of patients. But that's why it's important to, if you have suspicions, don't raise that suspicion of the trafficker. We don't want the trafficker to know what we're thinking. And we just want to keep everyone safe. Again, safety is #1 priority. If you feel that asking a certain question is going to jeopardize that, then just don't ask it.
What about a nurse outside of the ED? So in the instance that the ED is bypassed, they're direct admission, they come from a doctor's office, they're transferred from another hospital. Do the nurses on the inpatient units get the similar training as the ED? But also, sometimes you have a victim who's, let's say, been in a car accident, they're unresponsive, they're in ICU. They start to wake up, we recognize there's something wrong. Is what we do in the ER the same as you would do in the inpatient area?
Yes, it is. Yep. With our inpatient areas, we are lucky to have the SAFE program, so they can call us for guidance and we can hop up there and see what we can do. Regardless of what area of the hospital, or even if you're in a satellite clinic or in an urgent care center, the response should be trying to separate. If there's any issues with that or any safety concerns, just stop. If you are able to separate, just express that concern, let that patient know this conversation is confidential, obviously, unless they're a vulnerable adult or a child, and just let them know, I'm concerned about you. I really want to help you. I have resources available, and let them make the decisions about how that's going to work out best for them.
Ashley, do you have any personal experience or situations where you had a victim refuse help, and how did you handle that?
I do. One that really sticks out in my mind that I don't think I will ever forget. It really left me feeling very powerless, that I wasn't able to provide help to her. So we had a young patient that came in. She was in probably her 20s. She came in for a physical assault. She was hit with a baseball bat at a motel and was brought in by an ambulance for medical care. And once the nurses started working with her, they recognized the red flags and called the SAFE program in. And what was really unfortunate is that she did not want to talk to us. She completely declined. She didn't want to have a conversation. She didn't want to accept resources. She did not want to talk. And when I'm telling you, this patient was textbook human trafficking, every red flag you can imagine. She had her hair cut off. She had chunks of hair missing. She seemed malnourished. She had tattoos on every area of her body that you could see. And they were mostly obscenities, and they were not professional. You could tell that they were probably done in someone's home. She had obscenities tattooed across her entire forehead. And it was very, very sad to see. And she wouldn't talk to anyone. So we knew that she was going to be discharged. And I went in early to try to have a conversation with her, and just try to build a rapport as quick as I could. By the time I was able to meet with her, she was already in our ambo bay, ready to leave. She was discharged from the hospital, and she told me she was waiting on a ride. So I went out and I sat next to her, and I explained who I was and explained that I was concerned and why I was concerned. I explained what kind of help I could give her. I told her that everything she talked about is confidential and I wouldn't report that without her consent. And we sat there for a little bit, and still did not want to talk to me, did not disclose, said everything was fine. And so I finally said, can I at least give you some clothing? Can I give you some food gift cards? Can I give you a phone? You don't have a phone with you. Can I just give you something so I know you're okay to be discharged? And she said yes. And this is where our team comes into play, because I called Melissa, who was the other human trafficking liaison who was in the office, and I said, get a go bag as fast as you can and run it down here, because she was going to be leaving any second. So Melissa comes scurrying down the hallways with what we call our go bag. It's an emergency bag. It has, again, the clothing, toiletries. It has restaurant gift cards. I got a track phone, and then we stuffed it with a bunch of human trafficking resources. And I gave that to her. And I told her, you don't have to disclose to me. I'm not going to pressure you into talking to me, but please come back if you need help. Like, we're here to help you. And then she told me, it seemed that she was on the cusp of disclosing. And once I gave her that bag, she seemed to trust me a little bit more. But she looked at me and said, if they pull up and I'm talking to you, it's not going to be good for me. So I said, okay, that's all you had to say. I said, I'm going to go sit in the hallway. I sat behind a glass window, so I could see her, but they can't see in. So I said, I'm right behind this glass window. If you need anything at all, just come right in and I'll be here. So I sat and I waited and I watched, and a pickup truck pulled up. Another girl got out wearing what was obviously a wig, big sunglasses and a hat. The girl came up, collected all of her stuff, and they just ran to the truck. And I knew I knew what she was going back to. I knew there was nothing I could do about it. And it was really, really hard because I also knew that I could help her. And I knew that I had amazing resources. I could have gotten her out of the state that night into a long-term shelter with amazing rehabilitative resources. But unfortunately, she didn't want to accept it, and that was her choice, and I respected her choice. But it was after that sleepless nights of, what could I have done differently, and what is she going through right now? And it was really hard on not just me, but our entire team. And, what I kind of realized is our job is not to rescue. Our job is not to save people. It's to give people the option and the information and the resources that we have available, and letting them make their own decisions. And I look back, and if I would have reported without her consent, I know she would never go back to a healthcare facility because she wouldn't trust us. She's not going to trust the nursing profession if we're reporting without her consent. It could have gotten her killed. If I was sitting out there that, when they pulled up, she could have been killed that night. So it's as hard as it is. I truly feel that if she needs help, she knows that she can go to a healthcare system, or she can come back to GBMC day or night, and we're going to be there for her. But it's hard for when we go into this field wanting to help people and wanting to help people have better lives and be more healthy and stay out of danger. And when patients don't accept it, it's traumatizing for us because we know that they could have anything that they wanted and needed. But at the end of the day, we have to do our best and respect the wishes of our patients.
Yeah, such a powerful story, and really illustrates, one, the fact that nursing is the most trusted profession, and two, how ultimately our patients do get to choose what care and what help they accept, even when it's difficult for us.
I want to just kind of think about the nursing perspective of this now, and seeing adults, children, et cetera, who've been abused, trafficked, that distress that it must cause emotionally in the nurse, especially those that refuse help, and then the nurse feels helpless, that there's nothing that they can do. What advice do you have for nurses so that they can, manage their emotions and reactions to these situations?
Great question. Yes, this is anytime you're working with any victim of any crime, or anyone that's been through a traumatic situation, it's extremely difficult work. And I can confidently say that the majority of nurses get into this field because we genuinely want to help people, and we want to provide care. We want to make sure that our patients are okay when they're discharged. And when it doesn't work out that way, it's really difficult. It's really difficult to process that. Personally, for me, with the patients that I work with, there's been a lot of sleepless nights, just sitting up and wondering, like, what could I have done differently? Like, if I did one thing differently, would it have changed? And we know that vicarious trauma is very real. We need to prioritize our self-care. And we really need to, as nurses, take care of each other, because seeing so much trauma, regardless of what type of trauma it is, it's not normal and it's not healthy. And we weren't designed to process. And also, like, we can't, as healthcare providers, we can't help other people if we can't take care of ourselves. So it's really important. Self-care is extremely important. It sounds pretty cliche, but I think healthy diet and exercise is important for self-care. And also having your team and being able to reach out to your team. So with our work, we have, obviously, with confidentiality, with HIPAA, but also a lot of our cases are legal cases, and they're still in that legal process. We can't discuss them. We can't go home and vent to our families about our tough day. We just can't. So having a team that's super supportive, I can't say enough about that. I know that even if it's 2:00 in the morning, I could call one of the nurses that I work with, and they would be available for me to run something by them or just to vent. At GBMC, we also have what's called a care line, where if you're going through a rough time, You can call 24/7 and someone will pick up, usually on the psychiatric department, and you can just talk through your feelings with them or get some resources and get some help. I would just recommend checking in on yourself regularly and knowing when to reach out for help.
Ashley, first, I just want to say I'm so grateful for the work that you do, because these victims are truly some of our most vulnerable patients that we serve. And it takes a special person to do the work that you're doing. So again, just from the bottom of my heart, thank you for the work that you do. We just greatly appreciate it. And I appreciate your time and spending with us today and educating our audience on this. Unfortunately, it's going to take us a while to fight this battle, if you will, of human trafficking, and your expertise is going to be incredibly valuable to our audience.
Thank you very much.
I also want to thank our listeners for joining us on this episode. If you have any feedback on this episode or any ideas for future episodes, please email us at podcasts@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's award-winning online leadership course, Fundamental Skills for Nurse Managers, with information available at www.aacn.org/manager skills.